Radio-ulnar synostosis. It's a bridge which can be fibrous tissue or bony tissue between radius and ulna. It can be congenital or acquired, that is post-traumatic. History will be painful, pain when it is incomplete synostosis. In complete, there will be loss of range of motion. Examine the child. Forearm is held in pronation, reduced size of forearm and muscle wasting. Scars, feel for the radial head, limited supination, less than 40 degrees, pronosupination block both active and passively. Function should be chest, hand to mouth, behind the head and behind back. Radial nerve assessment should be done. Examine the contralateral side. When I'm seeing radio-ulnar synostosis, I think of congenital radial head dislocation, which has reduced extension. It is possible to have associated with mid-lung deformity. It is need to exclude nail patella syndrome. In congenital cases, radial and ulnar divide from distal to proximal, therefore synostosis is usually in the proximal half. Failure of differentiation result in bony and fibrous synostosis, bilateral in 60% of the individuals. When seeing a patient, they have associations, that is KACA-DCC, KACA-DCC, Klinefelter syndrome, arthrogryposis, Carpenter syndrome, Apert syndrome, DDH, CTEV, and congenital radial head dislocation. Management: observe unilateral little functional deficit, radial head osteotomy, unilateral set in supination of 20 degrees, bilateral fixed dominant in mid-prone 40 degrees, and other in neutral. Cannot recreate proximal radio-ulnar joint with excision as it reossifies, and the results are not good. Mubarak procedure, osteotomies, and then casting to put place in an optimal position. So it's basically not osteotomy, corticotomy, and change a position and put a cast in very young children's. Post-traumatic radio-ulnar synostosis. The risk factors: number 1, both bone forearm fracture at the same level, one incision technique used for both radius and ulna, delayed surgery more than 2 weeks, violating bone graft into the interosseous membrane, prolonged immobilization, open fractures, high energy comminuted fractures, associated head trauma. The distal has the worst prognosis with excision. Middle third has the best prognosis with excision. Excision of synostosis. The result of surgery is unpredictable, and for others it is poor as well. What you can interpose: tensor fasciolata or fat graft interposition, followed by irradiation and endomethacin. Excision indicated when mature lamellar bone is formed. Too early before bone maturation can lead to recurrence. Too late can lead to joint contractures. Excision of the radial head for proximal synostosis will cause instability.